It's nice to see so many familiar faces here. I'm a little person, and so if you don't mind, I'm going to come down to you and share with you my little PowerPoint. And this is how we move forward.
Yeah,
right?
forward. Yeah, right
Okay.
is forward.
Okay.
Yeah.
Oh, this is much better. I like to see my audience. So I'm going to be talking about HIV and aging for long-term survivors living with HIV. I'm Jill Gover, and I'm a clinical psychologist, and I'm the behavioral health manager at Desert AIDS Project. I want to start off, and I'm going to dive right into this because I don't have very much time, and I could talk a long time about this subject, which is very passionate to me. I'm very passionate about. There are three categories of long-term survivors. Those who acquired HIV in the 1980s, who have been obviously surviving what we called the plague at a time when there was no medication. This is pre-HAART, antiretroviral therapy. And at that time, as everybody in this room knows, it was a death sentence. And so psychologically, there are very, very different needs today for those who are aging with HIV, who come from this time period, who went through these experiences of traumatic loss. I'll talk about a little bit more. So the psychosocial issues are very different for those people who are pre-HAART versus those who are post-HAART, the second category. And those people may have been diagnosed after 1996 and have been living with HIV for over 20 years now. So they're long-term survivors as well, but they face very different issues in terms of how they experienced their diagnosis initially and what they went through. In terms of, I often use the analogy of getting through or having gone through the 80s and 90s pre-HAART was very much like going through the plague or going through a war. And there's a great deal of trauma that's associated with those kinds of very intense emotional experiences of loss. And I don't want to forget the third category, which is all of those folks who are HIV negative, who are partners, lovers, caregivers, those of us who were right there at the front lines of that war, myself I'm talking about too, who are also aging with secondary trauma. And it's important to remember that category of long-term survivor as well. So long-term survivors have many challenges. And I want to talk first about just a couple of statistics here. I cannot believe it, but we are actually entering in 2020 the 5th decade. Can you believe it? I go, wow, I'm really old. It's pretty amazing. And when we were doing stats a few years ago, in 2015, we talked about in 2020, right? And here we are in 2020. 70% of people living with HIV are over the age of 50. So just as America is graying, so are those who are here today over the age of 50. There's a majority. And of those folks, 94% of people living with HIV who are over 50 have at least one other chronic illness. I mean, this is true for all of us aging. It's generally common to have comorbidities, but an average of 3 conditions, right? So HIV may be a chronic condition, but it's usually one of several as people are aging. So they're dealing with a lot of medical issues. Okay, and people over the age of 50 account for 27% of the estimated 26,000 AIDS diagnoses in the United States. And of the estimated 13,000 deaths among people with AIDS, 59% were those over the age of 50. So it gives you an idea of what we're facing. People are still dying, and we still have many challenges. Okay, so let me talk just very briefly about the psychological challenges facing long-term survivors. It's really important to remember that those who are pre-heart, especially, went through a really horrific time where developmentally their entire social support network were dying. And it wasn't appropriate because these were people in their 20s and 30s, and people aren't supposed to die in their 20s and 30s, right? And so there was a great deal of loss, a lot of unresolved loss and grief, and this all is traumatic. And people who have sustained trauma manifested psychologically in these ways. There's, as Dr. DeVries noted, there's a higher percentage of depression, anxiety, emotional numbness, a great deal of anger. Why did this happen? There's also sleep disturbance, insomnia, hypervigilance, substance abuse, low self-esteem, and social withdrawal. And these are all the effects of sustained trauma, the symptoms of post-traumatic stress. There's also survivor's guilt, which has to be addressed, and a tendency to isolate because people become reluctant to form new friendships, new social connections when they've had so much loss. There's still a lot of stigma due to the fear of contagion. And let's not forget the ugly head of ageism, which is still very much alive everywhere. There's also a challenge that long-term survivors face within the LGBT community because there's also often this perception that the community itself has shifted its priorities. And now that people aren't dying in droves from AIDS, that they don't really need services anymore. And of course, that's not true. There's also some socioeconomic issues that are challenges for those who are aging with HIV. Many people never expected to live to retirement. It's, those in the pre-heart long-term survivors, the average lifespan was like maybe 2 years, right? So people just didn't think they would ever get to this age where they would actually be aging and being an older adult. And they didn't save for retirement. And so many are living on SSI or SSDI, where financially they don't have the resources they might have had they not been diagnosed with HIV. There's a gap in work history because for those in their 20s and 30s who are just starting and launching their careers, uh-oh, that was a sign. I better hurry up. Their career trajectory is derailed, and so there's gap in their work histories when they got sick, and maybe they might be able to work now, but they're not current in their skills, and of course there's a great deal of ageism in employment, and try finding work when you're in your 60s in an urban area. It's very, very difficult. Those who want to work can't find work. But some have to remain unemployed or in low-paying jobs because they can't afford the medication unless they stay in these low-paying jobs and qualify for government-funded medications. There's the lack of affordable housing, as mentioned before. And Dr. DeVries talked about logical family. The issue about logical family is that many of our logical family are close in age, that it's not the same as when you have biological family where you have children and grandchildren and you have a younger generation coming up. A lot of logical family is roughly in the same age range, and so as people are aging, they're also losing their family support system. And that is a real issue for those who end up alone and losing their social network. And long-term care is not available for those on disability. I want to talk about the challenges, and I'm just scratching the surface here. We have some very, very effective therapy that's available to address the sustained trauma. These are all evidence-based therapies. The trauma-informed therapies of Seeking Safety is an example of a manualized treatment that's very effective. There's mindfulness-based stress reduction. There's cognitive behavioral therapy and exposure therapy, behavioral exposure therapy, which is very, very effective for treating trauma. There's eye movement desensitization and reprocessing, and pain management treatment, all of which really, really helps to overcome some of those effects that I mentioned earlier around sustained trauma. There's also peer support services that are very therapeutic. All of the programs that Candace talked about earlier. There's also Let's Kick Ass, and ASS stands for Acquired AIDS Syndrome. Acquired AIDS Survivor Syndrome, ASS, sorry. And there's a very active chapter here in Palm Springs for LKA, and all of the other social events that help people break out of isolation and connect with each other and come together around shared experience. What is resilience? Resilience embodies the personal qualities that enable one to thrive in the face of adversity. People who are aging with HIV have experienced great adversity. And resilience describes a process whereby people bounce back from adversity and are able to go on with their lives. And this is what we want to promote through all of our services. We need to reduce stigma. We need to help people find employment. A shout out to SageWorks. It's an amazing program to help older adults develop computer literacy. We need to change self-perception so that people gain confidence in returning into the workplace. We need to do a better job of making retirement homes LGBT welcoming. We need to be proactive around our own care, eating properly, exercising, taking care of health needs. That's important for everybody who's aging. It's specifically important for those who have a chronic illness. Very quickly, because I know I'm like done. How many of you know about the Blue Zone research? Yay! I've been talking about the Blue Zone research for over a decade, and when I first started talking, there was like nobody who knew about it. This is my favorite research. It's the research done by Dan Burtner and his team around centenarians. It's around what allows these people aged 100 years and older who are living independent, healthy lives, what do they have in common? And the Blue Zone are these places on the map where there was the largest concentration of centenarians. And they are Sardinia, Italy, Okinawa, Japan, Loma Linda, our backyard, and Nicoya Peninsula in Costa Rica. And what all of these really disparate places had in common was this. This is the lesson. And so this is what I want to leave you with. It's, in terms of healthy aging, it's so important for all of us, particularly LGBT aging. We need to keep moving, have a purpose in life. We need to be able to balance work and play. We need to eat wisely, eat less, eat more vegetables and plant-based food, stay social, participate in something that's spiritual, not necessarily an established religion, and stay connected to family, however we define it. Those are the key ingredients to healthy aging. So in summary, we need to build social networks to reduce the isolation. It's very important that we process traumatic loss and that we reduce HIV-related stigma, and we need to mitigate detrimental health effects of the virus and the medications, which also have negative effects. And Dr. Singh will talk about that in a sec, by making healthy lifestyle choices. So, thank you, everyone.
Hello, everyone. Can you hear me? I'm Dr. Singh. I work at Desert Age Project, and I serve persons living with HIV, infectious disease, and primary care patients. And I'm here to talk about the medical aspect. Jill did a great job about the psychosocial and psychological aspect, but there's a medical part too. So I'm here to talk about that. And if you guys have any questions, feel free to ask me a question, and then I'll jump back to my slide. So thank you for Lisa Middleton and this program for having us here. Let me start with my first slide, which is the topic is the care for the aging patient with HIV. The objectives of my presentation today is to describe the care continuum for adults aging with HIV, discuss the treatment options. You can hear me? Sorry. All right, and identify the manage and common conditions that affect aging population more. So, aging with HIV perspective, I'm gonna start with an example of a 74-year-old patient of mine. We'll call him Mr. H. He was diagnosed with HIV in 1984, and in those days, he said when he got HIV, it was almost unexpected that you live beyond 5 years. So here it is, 2019, and he's surviving and thriving still. So we have multiple patients like that in our practice, especially in Palm Springs. This is Mr. H's medical history. His CD4 count is not bad, it's 440. His viral load is undetectable because he takes his meds. He has hypertension, chronic kidney disease, osteoporosis, depression, history of skin cancer. And then he has 9 other medications along with ART, which is antiretroviral therapy, which is basically 1 pill once a day now. But we have to remember, although HIV medication is just 1 pill once a day, he has these other things that are going on that has him on 8 other pills. So one of the main things I want to talk about today is the polypharmacy. Other medication he has is testosterone, bupropion, which is an antidepressant, cholesterol medication, etc. He quit his job when he was diagnosed with HIV. He reports isolation from loss of his friends, which he lost to HIV and other conditions. He survived this long, but not everybody was as lucky. So HIV in the United States, I would say, Jill touched upon that very quickly. More than 50% of our persons living with HIV in the United States are over 50 now. In New York City, 1 in 5 people living with HIV are age 50 plus. Why do we talk about age 50? Because it's about, at this age is when changes of HIV infection in older people, but with age 50 years is around the same time because HIV ages you earlier. This is what we talk about 50. Usually geriatric age we consider is 65. There's a lot of comorbid conditions, geriatric conditions that are more common in persons living with HIV. So this is a care continuum. So very important to get diagnosed with HIV, but not only that, after that we need to be linked to care. After that we need to be put on antiretroviral therapy and then be suppressed. All that takes time, so it starts with diagnosis. PrEP in older adults, I wanted to actually touch upon this because I got a question earlier, and I don't know if I can say the name, but it's Jonathan Goldman asking, is like, hey, Jonathan. So I'm going to address this question because it pertains to my slide here. A friend was denied of PrEP by Kaiser as he's over 65. So he wanted me to comment on that. And I think what Kaiser is a closed system, and they have very set rules about following the guidelines. Most of the studies, and this is one of the problems with PrEP in older adults, is that they were done in younger adults, and there are very little representation in older adults, and which is not just the PrEP research, but most of the research does not represent older HIV aging community that well, which is why Desert Days Project, we're doing an HIV and aging research project, which actually Jeff Taylor is right here. We work very closely with HARP-PS, HIV and aging group, and we're actually looking at that aging population. Our research is solely on 65 and years older, and we're trying to include more and more HIV aging population in our research. So what we can do for your friend is, if he can come and establish care with us at the doc for PrEP, we will get him on PrEP. Is that, we can talk more, but that's, yes, okay. Because we can get patient assistance program, Gilead, we work closely with them. We also have now Truvada that's going to go generic soon, as well as the new government initiative, PrEP Access for All, starting next month. This is huge. This is going to happen. All the insurance will have to cover PrEP. So this is a golden time for PrEP coming up. All right, so psychosocial issues, Jill beautifully touched upon those. I'm not going to repeat those. Why is a person living with HIV have a little bit more problems getting suppressed and in care? So one of the reasons is that response to ART is different when we're older. So sometimes we're diagnosed older when we're with HIV, and by the time the T cells have dropped a lot, so it takes longer for them to recover. So that's one of the reasons that the comorbidities is higher in person living with HIV when they're older. Also, the rates of viral suppression is high. When they do get on medications, they do beautifully, they take it, they're more compliant, but the comorbidities and cognitive impairment, polypharmacies that reduce the efficacy of the medications and being on care. The other issue is that we have not done a very good job of researching what to start in older patients with HIV, older person living with HIV. So we don't have designation of, oh, if you're older, start this particular ART, this is safer. So that's another area where there's lack of research, which we're actually going to do. Concurrent medication, polypharmacy, I talked about it. 5 or more prescription medications is polypharmacy. There's a lot of drug-drug interactions we have to think about. So like I said earlier, not only just the ART, but other prescription medications for nervous system, cardiovascular, gastroenterology, endocrine, blood disorders, and then supplements. A lot of patients don't consider over-the-counter supplements as medications, but they all interact. They all add to the burden of liver and kidney. And so we have to always ask if you're on any antiretroviral plus other medication, herbal, over-the-counter, because they all add up. What can we do as clinicians, as people taking care of patients? We should all be assessing them for not just ART, but also over-the-counter medications, and then also consider prescribing quality measurements. There is recommendations for medication that should be avoided in 65 and over. We should look into that. There's a condition called HIV-associated non-AIDS condition, which is also more prevalent in person living with HIV, especially aging. And some of the things you can look at here is kidney disease, coronary artery disease, heart disease, bone disease, cancer, liver disease, neurological disease, and then polypharmacy. Geriatric syndromes are so common in older person living with HIV, including difficulty with activities of daily living, cognitive behavior, impairment, depression, visual impairment, falls, hearing problems, incontinence, difficulty, mobility. Increased risk of bone disease. A lot of us were on TDF before the TAF, the safer version of Truvada came out, so we have a lot of bone disease. HIV-associated neurological disease, this is a condition that she also touched upon a little bit, but HIV infection penetrates the brain. It can cause early dementia. So ask about any geriatric condition, assess the functional status, and in summary, across the continuum, older adults are most likely diagnosed with HIV need to know and think about screening and prevention of other conditions, comorbidities, medications, age-related changes for ART, increasing propensity with HIV-associated, non-associated conditions, and then functional status, always assess for that because just taking ART is not enough. Any questions? I was on time.
It's on time.
Thank you. Thank you.
Thank you, Dr. Singh. In fact, you were abbreviated, so I appreciate that. We have time for one question, besides the one that you already addressed, which I appreciate. The question is, HIV and aging, such as AIDS survivor syndrome, seem to focus on mental health. How do we address cofactors of psychological as well as lifestyle and physical limitation due to long-term medication side effects? So either of you, please, and then we'll get ready for the next panel.
Well, one thing that I want to say before I turn it over to Dr. Singh is that it's very important to look holistically at an individual, and the mental health and the physical health are inextricably intertwined, and you really can't separate them out. So when you are addressing mental health issues and building resiliency, you're also strengthening the physical body at the same time that you're reducing the depression and anxiety that always surrounds dealing with a medical condition. So I just think it's very important to think about them together. Mental health, psychosocial, lifestyle changes, behavioral changes, all of which support health in an umbrella concept.
I would echo that. We actually, on the first visit, we always ask the patient, and if we see any signs of depression, anxiety, any social issues, psychosocial, we refer them to psychologists as well as psychiatrists, so that process starts from the get-go, because mind and body connection, if you're depressed, you're not able to take your medication, that affects the numbers, that affects my numbers, and I like my patients to be undetectable.
Okay. Thank you very much, Dr. Gover, Dr. Singh. Welcome
Thank you.
Thank our panelists. All right, Riku, Robbie, Patty, and Dr. Jill, will you come on up?